Good morning, and thank you for joining us for today's Healthcare Forum, presented by the TCU Neely School of Business and the TCU and UNTHC School of Medicine. My name is Alana Zaga, and I am a first-year medical student at the School of Medicine. In addition to welcoming you to this morning's program, I also wanted to share why I chose the TCU and UNTHC School of Medicine. From the moment I heard the phrase empathetic scholars, I knew this school was where I belonged. The emphasis on training compassionate doctors skilled in communication was so clear to see, especially since we start seeing patients in our first year. As a self-starter, I valued the flipped classroom model and cross-department curriculum, as well as the unique course our dean teaches, the Future Accelerators of Medicine and Beyond, where we learn about the future of medicine. Beginning medical school during the pandemic has presented some challenges, but we are learning in real time what it is like to be in the middle of a public health crisis. Please enjoy the program this morning, and I'll pass the baton on to my colleague from the Neely School.
Good morning. I'm Mark Philippek, and I'm finishing my second and final year of TCU's Healthcare MBA program. I came to this with 20 plus years experience in a completely different industry, and I joined this program because I want to make a career switch into healthcare. After considering various options, I picked TCU's Healthcare MBA mainly because it's a very well-rounded program. First of all, it's an MBA. So whether you're trying to grow your business acumen with a greater understanding of finance, accounting, supply chains, analytics, and strategy development, or you have a healthcare background but are new to business concepts altogether, you're getting the education you need to compete and be successful in any business, and specifically in the business and operational side of healthcare, whether that means working for a provider system, a company that supplies to providers, or opening your own practice. Second, TCU's program exposes you to the unique challenges of healthcare. Most interestingly, what makes this huge and important industry that touches every single life so complex and different from any other industry. Now, I do have a business background, and looking at healthcare from that outside perspective, there's so much that doesn't make sense. But through the program's coursework, I now understand how we got to this point, the political and societal forces that shape the industry, how the economics of healthcare defy traditional microeconomic models, and how to create meaningful change through human-centered design and patient safety considerations. So all in all, it combines the best of both worlds, a broad and marketable degree with an intensive exposure into healthcare, its problems, and most importantly, how to be a part of the solution. So those are my reasons for joining TCU's Healthcare MBA program as a newcomer to the industry. And now for an industry insider's perspective, I'm going to hand things over to my colleague in the cohort, Dr. Theron Bowman. Theron?
Thank you, Mark. Good morning, everyone. My name is Theron Bowman. I am a third year internal medicine resident and chief resident with Medical City Healthcare. Aside from, and in addition to all of the opportunities that Mark just listed that TCU offers, I opted to join the program in order to, like you mentioned, broaden my business background in addition to the clinical perspective that I've gained over time as well. As we all know, healthcare is growing in its complexity and the problems with that. And so that is going to require some complex solutions, which often merge both clinical expertise and business as well. So one of my biggest reasons for joining the program was to take advantage of the opportunity to be able to speak both languages and to be able to gain both perspectives. And that's one of the guiding purposes of this annual forum, as well as to explore the intersection of business and medicine and how the two can work together to solve some of the complex problems that we have today. And I've had the opportunity to participate in the MBA degree as a resident, but I am excited though about the continuing collaborations between the Neely Business School and now the TCU Medical School, and the opportunities that will lie ahead for our medical students, for them to get more exposure even during their medical school training. So with that, thank you for the opportunity to be here. I'm excited for the future and what it holds and what opportunities lie ahead, not just for our business students, but for our medical students as well. And so with that, I'm going to hand it off to Ms. Judy Burness, who is the Chief Communications and Strategy Officer here at TCU and the UNT HSC School of Medicine. And thank you again for the opportunity.
Thank you, Dr. Bowman, and welcome everybody to the annual Healthcare Forum. We really prefer to see all of you in person, but we'll take what we can get this time of the year. So we're very happy to have you here with us, and we're excited to kick off this panel. We have a really great group of speakers, and I think you're going to thoroughly enjoy this morning's presentation. So I'd like to thank our sponsor, Jay Taylor. They generously sponsored our program this morning and are following up on their sponsorship, and they are a great partner. We appreciate everything that Jay Taylor has done. They've been a partner helping us establish the medical school and now continuing their partnership. We're very appreciative. This morning, our two moderators are our fabulous deans, Dean Stuart Flynn, founding dean of the TCU and UNT HSC School of Medicine, and my boss, so I fortunately got his name right. And also our fabulous Dean, Daniel Pullen. And Daniel Pullen is the John V. Roach Dean of the Neely School of Business. He is also a graduate of the University of Oklahoma and has a JD from University of Oklahoma as well. And I just learned he was homecoming king there. So I got to learn that little extra tidbit about you. Dean Flynn is a graduate of the University of Michigan School of Medicine and did a fellowship in oncologic pathology from Stanford University. They are going to be your hosts this morning for this wonderful discussion. And with that, I will hand it off to you, Dean Pullen.
All right, thank you, Judy, and thank you for digging up a bit of the past in an unexpected way. We'll talk more about that offline. I'm really excited to be a part of this conversation today. I think it's one of the great opportunities we have when we have the opportunity to associate with a great institution like Texas Christian University. In so many ways, the Academy is so well positioned to curate and cultivate conversations like the one we're going to have today on fast-moving and important topics like artificial intelligence. It is a remarkable chance for us to operate at the intersection of the academy and industry and to provide not only a forum, but also thought leadership to help shape and tackle the greatest challenges of our time, whether that is in the healthcare industry or business in general, or really how a place and a people in a broader society are positioned to respond to unprecedented moments like what we've all endured together in this calendar year 2020. So as we focus specifically on artificial intelligence today, I know it's a broad and encompassing topic. It certainly covers everything from healthcare to transportation, supply chain management. We're seeing AI used to, buy and sell securities and finance. In marketing, we see it used to assess and analyze customer behavior, increasingly shape customer behavior. And so everywhere you look, it's upon us, and therefore we have to understand it. We have to grapple it. We have to understand how can we use the power of artificial intelligence to enhance the promise of humanity, both in the private sector, public sector, and really for all of us, even at the individual level. So it's an important conversation that I'm just thrilled to be a part of. I think we are all aware of, or at least intuitively, about the importance of advances in artificial intelligence as it pertains to healthcare. It is allowing us to take care of patients in a more enhanced way. It's allowing us to more efficiently and effectively manage large healthcare systems, organizing increasingly voluminous amounts of data to help us drive better decision-making as we care for our citizenry. And in particular, over the last 9 months, as we have all endured the COVID-19 pandemic, I think we have seen artificial intelligence on full display. And so let's learn more about that today. And we're going to do that today by having the pleasure of welcoming to the TCU community two international experts in artificial intelligence that'll help us really dig into the opportunities and challenges that are upon us. So at this time, my colleague Dean Flynn, if you'd like to introduce our panelists, I think that would be just wonderful. Thanks everybody for being here.
Well, thank you, Dean Poland. I have to say, the comment on Homecoming King has just kind of sent me off the rails here. So I have to recollect my thoughts. So on a serious note, Daniel, it's just such a pleasure and, dare I say, even an honor for our two schools to host this event. And I also want to thank, as Judy has, Jay Taylor for their sponsorship.
8 o'clock.
I'm also very pleased that we're discussing this topic today, as our medical students have found themselves right in the middle of a historic pandemic that absolutely will and already has changed the way medicine is practiced. We're also watching what is an ever increasing impact of artificial intelligence in healthcare. I think it's a pretty safe prediction that AI will become a seamless tool as our graduates care for their patients and will be critical to significantly improving health and care for all of us moving forward. I would now like to introduce our two panelists, both of whom are truly valued colleagues for our medical school, and I'm just so honored that they play very significant roles for us. The first panelist I'd like to introduce is Sai Bezawada. Sai leads IBM's public sector business unit for the state of Texas, serving clients in the state, local, K through 12, higher ed, and transportation. Sai's been with IBM for 22 years. Prior to joining the Texas team, Sai led large transformation projects as a client partner for Fortune 100 clients. Sai's a certified executive project manager and has a master's degree in mechanical engineering from Wayne State University. He volunteers with the North Texas Food Bank and is on the advisory board at Collin College, helping shape their curriculum to prepare students for the future. And Sai continues to be a wonderful partner with our medical school, participating in a dedicated week that we have for our first year students on artificial intelligence and machine learning. He doesn't know this yet, but he's about to get an invite to teach again this year. So he can send me to his junk very quickly since he's been forewarned. I want to now introduce the other half of our panel, Steve Miff. Steve is the president and CEO of Parkland Center for Clinical Innovation, a leading nonprofit artificial intelligence and cognitive computing organization affiliated with Parkland Health and Hospital System. Steve and his team focus on leveraging technology, data science, and clinical expertise to obtain unique social determinants of health data. Steve was the recipient of the Community Council of Dallas 2017 Social Innovator of the Year Award and the 2020 Dallas Business Journal Most Inspiring Leader Award. And fortuitously, as I'm thumbing through the Dallas 500 magazine last night, I turned the page and who's looking at me, but boom, Steve Miff. So congratulations, Steve, for also being recognized in that fashion. Steve earned his PhD and his MS degrees in biomedical engineering and a BA in economics from Northwestern University. Steve has also served on several boards, including the City of Dallas Data Science Technical Committee and the SMU Big Data Advisory Board. As I mentioned, Steve is also a faculty member for our school, and like Sai, has been a fantastic mentor for our medical students. So welcome, Steve.
And thank you so much for having us.
So Dean Poland, I'm going to pass the baton to you and let you start with the first question.
All right, thank you very much, Dean Flynn. Artificial intelligence can be a really broad term. And so maybe as we frame and orient the balance of the discussion, maybe both Steve and Sai, give us a sense for how do you define and describe artificial intelligence? And maybe in particular, what does it mean in your world right now?
I'll take that first. AI has given me a set of capabilities that would help drive a personalized experience with the citizens I serve, along with solving big problems. It has kind of helped me think big. And so in the time we're here, the world would have created, let's just say, tens of quadrillion bytes, right? I mean, data is being created even when we're sleeping for the first time in the last few years, all the gadgets. So AI provides these capabilities to understand and get to outcomes. So for me personally in Texas, it's during the pandemic, we were able to accelerate, how we solve these problems. And AI was a critical set of capabilities to that equation.
I think, Pooran, to me, the applications of AI is a really tangible way of how we bring back whole person health at scale. And what I mean by that is, I'll go back to both my parents are physicians, and early in their careers, they used to do home visits. And that was just so rewarding because they got to know that whole family. They knew the father and the mother, they knew the kids, they knew the grandparents, they knew what was important to that family, what decisions they're trying to make. They were part of their life for many, many years. So they had all those different insights in addition to their knowledge about their health and health care. However, as personal as that was, it was not scalable. Fast forward to recent times, and we've introduced so much fantastic technology, the electronic medical records. We've been able to scale and bring that data to the point of care, but we've been focused so much on that information and spending so much time with our machines that we've lost some of that personal components. So what I believe AI can do is bring all this information together, not only about the health and healthcare, but those other important characteristics about somebody's life in a way that's tangible, in a way that clinicians at the point of care can use it and bring back that whole person health, but being able to do it at scale. So I think to me that's where the potential for AI is. And as we go into the discussion today, I think it's important to appreciate that although we use AI broadly as exciting new innovation, there are different elements of how AI can be used. And that's how I think the industry is evolving as well. Anywhere from just supervised training where we learn known patterns. And I think the initial applications for this, that's where they've been, whether we predict sepsis or early warning systems, et cetera. We're quickly moving more into the unsupervised territory where we learn unknown patterns to be able to cluster patients, to be able to understand characteristics well beyond just the medical needs. And we're starting to see some application in this reinforced space of AI, with generating data, things such as chemotherapy, clinical trials, dosing regimens, etc. So there's an exciting evolution that's occurring, and I think we're going to cover some of those here today.
Well, Steve, I really appreciate that perspective, as a compliment to size. The whole notion, I think a lot of people intuit the digital and technological advances of AI, but lost in that conversation is actually that it can help bring back some of the human dimensions that maybe we're missing for far too long. And so I really appreciate that perspective. And maybe since you're on a roll, Steve, help us understand the inflection point as it pertains to the future of AI that was necessarily the COVID-19 pandemic. I mean, you've been thinking about this a long time. Where was AI going before the pandemic, and what have we learned about it that might alter its course looking ahead?
Yeah, no, I think it's a great question. And, the pandemic, as in all aspects of our environment, we've seen the need to innovate faster, broader than ever. Before the pandemic, I think we've seen increased targeted applications at the point of care, leveraging AI for identifying risk proactively and upstream. What I mean by that is predictive models that help with readmissions, or predictive models that help identify patients at risk for sepsis 8-12 hours before the onset of symptoms, deterioration of patients, or applications for adverse drug events. The other part of it has been more on the population health side, where AI has been used effectively to identify at risk, or I would say rising risk populations, whether it's for asthma or whether it's for preterm birth, et cetera. So those have been well progressed direct applications at the point of care before the pandemic. And what we've seen also starting to accelerate is progress across the specific areas of the ecosystem. They're actually required to support AI, because AI by itself cannot be that effective. So whether it's moving data around, ingesting data at scale, whether it's how do we actually link the data across all these different domains, making sense of it via next generation data visualizations and those end user insights. We've seen quite a bit of progress, there. With COVID, what I think that has happened is it accelerated partnerships for better and broader access to data. Has infused the need to bring in not only health data, but data about the community, data about individuals, data about mobility and other types of elements that are important as we're trying to understand and manage the pandemic. So those are some of the elements that I believe the pandemic has forced us to accelerate and build on some of the things that were already in progress.
Absolutely. Well, I think that acceleration, and then the obviously the insights and decision making that flow therefrom, perhaps in the long run, could really advance humanity at a pace that, but for the pandemic, we might not have seen. Dean Flynn.
Thank you, and thanks, Steve. Cy, Steve just very nicely brought us up to today with the pandemic. We're all very excited looking forward as to trying to mitigate this and control the pandemic. I'd maybe like you to put a little bit, look in the rearview mirror a little bit. When this all started, when we started to get the first kind of notice that something was brewing back just as 2020 turned the corner, a lot of confusion, a lot of questions, a lot of uncertainty, and I don't need to relitigate a whole bunch of other things that played out. I'm curious if whatever you think you can share, how did IBM approach this with resources like Watson and Watson Assistant? And what was the company looking to as their possible role during this pandemic, which I'm going to anticipate was kind of a moving target as we learn more and more?
I clearly remember it, Dr. Flynn. It was first week of March. We're coming back from spring break. We landed in DFW. Everything was shut. We worked over the weekend. It was all hands on the deck. Our first priority was our customers and the communities we serve and our employees. So we took all the technology we got, all the automation, Watson, and we figured out how to get our clients, our team, business continuity. How can we help them, get back and do this at minimal disruption, whether it's, provisioning laptops or, spinning up these cognitive agents so that they can get help. As you clearly, recalled, it was a moving target. In parallel, our thoughts were, how do we take the technology we have, the technology assets we have with Watson and cloud and all of this, and how do we put this in the hands of our research community? How do we put this in the hands of our frontline, heroes, our doctors working some of these? And so we moved very quickly to come up with those configurations. It's almost, as Steve mentioned, I mean, this pandemic has accelerated so much of what we can do. So it acted as a natural filter of what we absolutely need versus what, it's good to have, right? I mean, that little font on the left-hand side, it was a non-issue, right? It was, we got to get this functionality into the hands so that the researchers can go look at, various drug molecules or whatever. So those are the two broad themes we set out, with full understanding that as data evolves, as information is coming from the field, we got to change, right? I mean, it was, initially was school closings, then it was school openings, and then, somewhere in between, you got to wear a mask, but maybe not. So we're constantly adjusting, adapting, and making sure, our systems that we put in the hands of our citizens are reflecting, the accuracy of that data, and being able to help. So those were our two main priorities, with business continuity and enabling our frontline researchers and colleagues in the medical profession.
So unfair question. I was going to ask you to grade how you predicted all of this, but maybe a safer and more fair question is, what's one of the biggest things that you and IBM learned that in middle of March you didn't even have it on your radar, and maybe you had everything on your radar?
The speed at which we can move. I mean, so we've been doing Agile for more than 3 to 5 years now, right? Where we look at in 2-week increments. But boy, when you got only 2 days, right? You got a weekend, and a call center that's getting 100 calls is now getting 10,000 calls, right? So, how do we move quickly? So I think we've been impressed with the speed and how quickly we can move. I mean, as a company, I run with a colleague the Texas business unit, and so we have some freedom. But nationally, how we've mobilized and got on the same page, just a little over a weekend, right? I mean, it started Friday night, and then we were looking at a hospital in Florida. They needed something for their neonatal care on fielding questions, and so the ability to adapt to this. None of this technology was in per se. I mean, we've made some improvements for pandemic, but it was already there. What made a difference is the creativity of the people with the customers and the community saying, "Hey, this is what we need, right? Can you configure it quickly?" I think the ability and how quickly we moved was just a good surprise for me, right?
Very impressive. Thanks, Sai. Dean Pullen?
Yes, I loved what you said about the creativity of people coming together, and I think that really underscores the power of partnerships. And we, obviously, we've just mentioned the strength of the partnership between TCU's medical school and the business school. We've talked about how TCU as an institution is partnering with industry and the broader community. And so Steve, talk about one of the partnerships that really jumped out at me that you were involved in. You partnered with the health department. And in that partnership, you provided real-time exposure information, which was critical. So how did that partnership come together? How did you make it happen? And then how were you able to, as Sai said, bring the creativity of multiple people to provide such precise information in such a timely way?
No, great question, Dean Pullen. And just like everything else, if you wait for a crisis, you're probably too late. So whether it was strategy or whether it was luck, it was a partnership that we've been fostering and working on for quite a while. So there was already, the partnership was already in place. There was the trust there, which I think trust is a key word that we've had to just rely on even more during the pandemic. So we were able to early March, as I was saying, just reach out and formalize a data sharing exchange with the county. So since then, on a daily basis, we receive 100% of the cases and the information for the COVID-19 at the individual level. So with that also comes not only the trust, but a lot of responsibility. So some of the other things that needed to be in place was a robust digital data environment to securely ingest the data, protect it, et cetera. But in addition to that, was also quickly trying to establish new partnerships, because there were increasingly new data that was available that we didn't necessarily look at or have access before. And that was one of those was mobility data, where all of a sudden data from Google, Apple, SafeGraph, and others became more available. So being able to bring that information in and being able to merge it with the other information became very, very relevant right at the beginning. And then in addition to that was developing some new techniques around geomapping, around visualization, new algorithms. So just getting data in, it's a necessary first step. But then we really focused on where we can use that and contribute the most. And there are 4 areas that we focused on initially, and we've continued to focus on and expand on since then. And those 4 were really the ability to visualize on a real-time basis and provide that back to the county, the city, the healthcare environment, so they can actually track and understand the progression of the disease across the community, but also do a version of that that maintains the privacy to the community. So the community can also understand how this plays out, and they can be an equal partner in those conversations. So one was this ability to really transition and translate the data into a way that can be visualized and interpreted by a whole host of different entities. Number 2, we developed a proximity index to really understand at an individual level the exposure. Also a vulnerability index to understand which parts of the community are at greater risk as the disease progresses. And finally, the 4th one was a capacity planning, prediction, and forecasting model for Parkland and other healthcare organizations, so they can anticipate what the bed needs are, what the ICU needs, ventilators, etc., so they can plan not only for supply chain and staffing, but some of the other components. So those are the 4 areas that we took this information, we took these new things, and we started to translate into to inform the community and those that were working directly.
I love that. I mean, I think it's, there's the partnership, the facilitation of the acquisition of data that partnership allowed for. But it's not just the data, right? It's then being able to bring the human intellect to triangulate that data, make sense of it all, and then have the human sensibility to really understand the implications, including things like privacy, including things like security and vulnerability, to make sure that data can actually be used for the constructive good, and isn't to just operate in the absence of human intuition and human discretion. Stuart?
Thank you. So I think, again, we got off track a little bit at the beginning. I won't repeat why again. That will be for another conversation. We did forget to tell the audience, please, you can ask questions through Q&A. Daniel and I will filter them. We will only ask the questions that we want to ask. So just understand there's editorial rights in this. But seriously, throw questions out here. We'll have time to ask them also. Sai, you had mentioned previously, I believe within a matter of days in March, you heard from a neonatal unit in Florida. So I'm kind of curious if you would share, what did the healthcare and research communities come to you, kind of the big ticket items, to ask IBM for help? And then maybe give us one thing that was asked for that was just really out of your wheelhouse, if that's a fair question.
Yeah. No, just to put things in perspective, just like Steve, my parents are physicians and doctors too. Dad was a microbiologist, mom is still practicing OBGYN. So from a medical standpoint, I had a vested interest at a minimum to keep up. So when my mom asked, hey, what's going on with sepsis? What are you doing? I mean, what white blood cells? So I was keeping up with that and just to make sure I serve, I'm getting the latest. And she's also an asthmatic. So, I had double pressure on me to make sure I up my game in this space. just from a clinical side, I know Steve mentioned sepsis. We've launched some projects with a partnership with a school up in the Northeast. Sepsis was one, but also we looked at the use of ventilators. As we all recall, there was a tremendous shortage, and the settings on it, how long you want to keep a patient on it, what is the optimal settings, and looking at the data from a lot of patients. So those were the type of use cases that we were looking at it, right? How do we, where the eye would miss it, right? How would you correlate that data and maybe do it more broadly so that you're not missing something. So that was one. And Dean Flynn, you mentioned something that's not in our wheelhouse. So PPE shortage was very big, right? I mean, we were having all kinds of shortage from toilet paper. So PPE was right at the top. And non-traditional suppliers were stepping up to produce this, whether it's in Brazil, Argentina, all over the place, where hospitals did not have that part of their supply chain. So we've launched with partnership from the community with our blockchain solution and AI, we've launched Rapid Supplier Connect. So this would, build that trust, right? I mean, this would help find a supplier somewhere that you haven't done business before, where we would certify through whatever means and just give you that assurance that yes, you could buy the product. And that was a huge help. I mean, we had the technology, but we really got out of our comfort zone and started, bringing and collaborating that so that, the hospitals could get what they need. That's on both the clinical, non-clinical. Just from a research standpoint, drug discovery, right? I mean, almost, 3,000 plus drug molecules we made available. Our genomics platform, right? I mean, over 10,000 genes where, researchers can get in and kind of do whatever computations they have to do. One thing, that caught my attention is there was a need to serve information in a simple way. I mean, we didn't have time to go through 100,000 documents and 70,000 peer journals, all of that. So we put that and provided that access to the researchers so that they can just go simply ask questions. Hey, show me what's going on yesterday, and all the curated information, and it would serve it up in simple terms, so that they didn't have to go through reams of a simple use case, but it proved very effective.
Great, thank you. Don't answer this right now, but if IBM has a little stash of vaccines, Daniel and I would be interested in just seeing if we could queue up, but don't answer that now. Don't wait till we're offline on this. Let me throw out to both of you. I don't need to comment to any length at how our society is significantly split on many, many views about COVID and other things. So what has been both of your experiences in regards to how the information you're coming forth with has been received by the public, and then secondarily by physicians and researchers? And that's for both of you.
Well, I guess I'll jump in. Dr. Flynn, great question, because I think there's been so much, debate and differences of opinion. What we've tried to do is not get into or pick a side, but tee up information in a way that both individuals, the local municipality officials, clinicians can make decisions and use that information to enhance the decisions that they make, and not try to influence necessarily what those decisions are. So from a public perspective, it's been really a focus on creating awareness and putting that information so individuals can access this, anybody can access this, and visualize where they are relative to the emerging hotspots where we see cases, active cases across the community, and how that progresses over time. So not only seeing them being able to visualize where they themselves sit relative to the progression of the disease, but also see where potentially some of their family, colleagues, etc., across the broader geography. Similarly, to be able to understand their own vulnerability, understand their own risks, and use that to hopefully influence their behavior as the recommendations, national, local, around masking, social distancing, washing hands, etc., continue to be reinforced. For the physicians and researchers, it's really the same information, just making much more granular in nature. So actually, they're not looking at the whole population, but they're looking at individual patients. And maybe the best example that I can use is one of the things that we developed, and that was this concept of a proximity index, because it had to solve for a couple of different things. How do you maintain privacy so folks don't feel like you constantly looking over their shoulder, yet provide information that's granular and specific enough where it's meaningful. And this concept came about that right at the beginning of the pandemic. Sai was mentioning he was coming back from spring break and in the airport. One of the first questions that folks were asking from a triage perspective was, did you travel to China, or were you in Italy? And the reason for that question was because if you were in those environments, you were likely at a higher risk of being exposed, because there were a lot of people around you potentially who were actively infected with COVID. So that became an initial triage question. Well, as soon as sort of the COVID became active in our backyards, that question became irrelevant, yet none of us knew, were we around or are we around anybody that's infective or active. So we thought that by having that very specific individual-based data, real time from the health department, being able to geomap that, we have a knowledge of the footprint of where the cases are across the community. So we took that and built an AI machine learning algorithm to really calculate an individual's proximity risk of exposure to COVID based on who was around them. So dynamically calculate the radius of how many, the density of cases, the distance to those cases, and create a index score that will give somebody a sense, again, at the individual level, around their living situation, how many cases, what the proximity is. And that started to become a very effective triage tool. On the clinical side, we started in April and deployed this at Parkland, and we quickly ran this across all 500,000 plus patients that over the course of the year have come to Parkland. And the way the clinicians used it first was to understand who is scheduled for an appointment over the next 48 hours. If that individual had a high or very high proximity index score, they'll proactively reach out to them and change that appointment to a telemedicine or a virtual appointment. So, if somebody's a high risk, let's not bring them into the clinical environment. Let's see if we can address their needs in a remote telemedicine based way. Now, that over time that's evolved now. Every patient that proactively that score is being reached and somebody shows up unscheduled in the emergency department, that score pops up into the electronic medical record. So again, that individual can be triaged in a different way. Let's not have them wait in the emergency department waiting area for hours, being around other patients that can be exposed. So that sort of has evolved. Our thinking has evolved as well of how do we provide this information for individuals themselves. So what we're actually getting ready to launch in a week or two is something that we call My Personal COVID Index, where an individual themselves via an app can go in, register and put their address, and on a daily basis, they see what their proximity index risk is. And this was an effort, how do you provide more that personal granular information that we've been using on the clinical setting to individuals? I've been piloting this with our team, so it's actually very informative and exciting to actually go every day and see has my index change given on the dynamic on how the disease progresses. So that's a good example of how do you actually take all this information and tailor it and make it available in a way using AI for the topic conversation for today at the point of care, depending what decisions different individuals are trying to make or trying to inform.
Sai, anything to add?
Yeah, I'll just add to that. As Steve mentioned, we pivoted to facts, right? I mean, we were delivering information from the authorities, CDC, and trusted sources. Just how were the public and researchers, all of those seeing? If you go to weather.com, which is an IBM business, we've kind of put in a map based on your zip code. If you're willing to give your zip code, it'll give you, what is going on. It was very successful. We had over 300 million visitors looking at it, but just keeping that to a trusted source level. I mean, we already had a lot of the geo data, and then we delivered a generic version of Watson Assistant there, right? To where they can go and look at where's my testing and things of that nature. But that's how we've been able to deliver this information to the masses.
Maybe, Daniel, give me 1 second here. There's a very nice question being asked by an audience member, and I know the member, so it pains me to say it's a good question, but I think it is a good question. What I just heard was a lot of value and acceptance in this crisis of your sharing data with society, with researchers, and with the healthcare team. Just expand that a little bit. This is a crisis. How are you kind of working through those who did not train to use these data to improve efficiencies and the like of their care, but actually flip it and feel like they're being challenged with their autonomy and their decision making? Can either of you just briefly kind of address that? Because until we generate the first graduating class from our medical school, virtually none of us was trained to take big data sets and kind of be exposed to them and value them.
Donnie, you want to go first?
Yeah, okay, all right. So one of the things, that's a great question. One of the things we've done, we've been very mindful of it is, how do we ensure that, you don't have to land a team of 10 experts to do this type of work, right? Because there's not enough to go around. So we've made a conscious effort to build our capabilities on open standards and, something where a front office person could quickly ingest and do it with low code or no code. Obviously, it's a journey. We got to get, but we've kind of had a head start on this even before that, even before the pandemic. It's just that some of the lessons we've learned is further going to accelerate that, that shift where you really, I mean, we're it, right? I mean, you're not getting help, right? And this, you got to go act on these data sets. So from collection, ingestion to where you get the actionable insights, it's a pursuit to kind of simplify that so that anybody, a doctor, could be able to do that. You don't need, hours of special training. That's what we've been focused on. Steve.
No, the only thing that I would add is that to me, the two foundational things that did not change pre-pandemic and during the pandemic is just during the pandemic have the frequency of it and the speed have accelerated. And one of them is the collaboration with the key stakeholders. So on the healthcare side, with key clinicians, and maybe the difference was that we limited, instead of doing with 10, we did it with 2. And the frequency of those meetings went from every other week to multiple times per week. At Parkland, we worked with Dr. Moreno, Chief Medical Information Officer, meeting with him several times a week to really advance and iterate on these things really quickly. that need to have the clinical input into any type of AI or any type of algorithm, any type that we built was critical, because it was not just building it. It was also how and where do you deploy it within the workflows, within the EHR, so that actually those that are the front line are going to be able to use it. Same on the health department side with their epidemiologists, being able to work and then collaborate and work hand in hand to understand those elements as well. And the second part of it was the transparency around the information, what's being built, what's data that's being used, what are some of the limitations, because it's not perfect, but you're understanding the limitations so those decisions can be made with that full transparency are equally important, were equally applied. So did not move away from those. It was just the speed and the cadence of it had to accelerate significantly.
Thank you. Daniel?
Yeah, so I'm really fascinated by the last couple of questions and responses. And so I'm going to ask a big question and try to put some of that all together. So we've talked about the importance of proximity data and vulnerability and mobility and open records and even ongoing educational efforts around the next generation of doctors and healthcare workers. Even in the business school, we've launched Masters of Science in Business Analytics to make sure that business graduates have the capacity to really put all of the volume of data together and understanding the value of partnerships to lead to insights that can enhance decision making. So fast forward a little bit. We've learned all these things, right? We've got educators and private sector, great companies like those that you represent, the healthcare department, all coming together with great learnings. What happens the next time? Are we going to have the tools and the talent and the will to tackle the next pandemic, whether it's a virus or another healthcare scare? Will we do a better job the next time, or is there still a gap between where we are and where we need to be to maybe not endure something so deep and painful and enduring?
I guess I'll try to take that one first. I think to me there are two parts to that answer. One, and I think we've talked through some of them. I am so excited and pleased with how much progress we've made as an industry and how many new capabilities we've infused to be able to address and continue to address the pandemic. Things around really the velocity, the diversity, the privacy of the data, those partnerships that have been developed will sustain and will continue. I think some of the applications and infusion of other supporting elements around the technology, whether it's telemedicine deployment, whether it's infusing and actually trusting, like you actually, the great question from the audience around this type of information and how can be used at the point of care. All those will be able to leverage. Some of these newer data sets, again, I think there was a lot of skepticism. There was a lot of concern about the appropriate use of mobility data. I think that's something that will continue to be able to evolve and use in a way that's safe and provides the individual privacy, because there's a fine line between progress and transparency and data becoming creepy, right, into privacy. But I think with the pandemic, we've gotten to a point where we can actually understand patterns and movement in the community and how we can actually use that to inform and target communication, how we pivot around and be able to prioritize where you put testing sites or where you put locations that people already access to make it convenient. So I think some of those things will continue way beyond the pandemic, and we'll be able to use the progress that we've made and expand it in other areas. And I think we've already seen that, Dimplon. While we built the vulnerability index to understand where the populations are across the community that are more vulnerable, and be able to tailor services, education, again, testing to that. We've already been able to pivot and use that for flu vaccination. As an example, because going to the fall, that was a big concern. So how do you pivot something they've done for COVID, similar to that from infectious disease, flu, and actually target vaccination around that? pivot that towards a vulnerability to schools. I mentioned about the school openings and how do you actually understand what schools, based on what they draw their students, tend to have more vulnerability based on the population. And now looking forward to informing how the actually COVID vaccines in that phase 2 with the vulnerable populations, that risk population, how that can be prioritized. And as that's being implied, how we can actually model, track the progress towards herd immunity across very specific neighborhoods across the community, so they can actually dynamically inform. So long way of saying is, I think we've created some things as an industry, infuse new technology that have accelerated, and we're going to be able to use this moving forward in much more tangible way and beyond just the COVID applications.
Yeah, so just to add to that, what COVID has done, it has forced us to think differently, right? And move at a speed that we haven't. What I see happening as we progress from this pandemic is where we had these one-offs where we were trying to solve for, hey, how do I better engage my citizens, or how do I get this? You're going to see an infusion of cognitive processes within the business processes. So if anything could be automated, it will be automated, right? I mean, so I see that trend. I also see, there's a lot of time. If you look at a pie chart, you spend 90%, 80% time on trying to find the data sets, curate it, and get it to a place with all the sources where you can act on it. I see that pipeline. I see that the whole supply chain of data getting more and more automated, where people are spending, you flip that and people are spending more time acting and, understanding and the data bearer rather than, feeds and speeds, right? I mean, they're going to go look at, what do I need to do to get to the outcomes? So I see that shift happening, right? I mean, this is here to stay, so.
Excellent. Dr. Flynn.
So maybe Steve Orsai, Steve, you gave a very nice commentary on tracking mobile data, my words, not yours. Use the word creepy, I'm not going to focus on that. But my assumption, and I didn't hear you say it, and I may be wrong, is a lot of this is maybe tracking cell phone movement. So at least for one person in this audience, namely me, can you just share how you accrue those data?
Yeah, so we don't accrue it directly. There are certain organizations that track that, but then provide it at the level that's not at the individual level, but summary across communities. So I think that's why sort of we've reached a bit of a nice compromise, where we're not we're not tracking an individual that gets into the creepy part, but if you can track communities, it gets into the cool part of it, where it's actually very useful. So for example, when we've been able to actually look at a block level and understand that is a huge hotspot of, for example, COVID. And that's also an area that has a high percentage of vulnerable population because they're over 65 comorbidities. Also, they have other needs, social economic needs, which puts them into that high risk category. Then being able to use the mobility data to understand as a group, not as individuals, but as a group, what are the places that they tend to visit the most? They go to this Home Depot, they go to this church, they go to this beverage depot, whatever there might be. Then it sort of starts to inform where do we need to put access points so that it makes it convenient, because they're already going to those places for other services. Where do you actually tailor the communication? So again, you meet the individuals what they are, having this broader context and understanding even sort of who are those individuals that they go, what type of ethnic and demographic component they have, so you can actually even tailor the messages that's much more ethnically and socially appropriate. So that to me is sort of the evolution of how being able to do this. I would say same with the proximity component, not tracking an individual movement, but the individual showing where their living situation is, so you can actually model around them. There are other apps, as you know, that actually be able to track proximity phone to phone via Bluetooth. But those have been challenging to be adopted only because of some of it being the privacy concern, some of it they're requiring a significant amount of individuals to have that functionality turned on for it to be effective. So we're learning to this, but I think that that fine line between how we use this information, we've learned some during this pandemic, and I think we'll continue to learn as we progress.
Right. Daniel?
Yeah, I mean, my last question, I know we'll have some time for Q&A here, involves an area of personal interest. We have in the Neely School a number of centers of excellence, one of which is the Supply Chain Innovation Center. And as we sit here this morning, I think that most folks believe we're just hours away from an emergency authorization for use of the first approved vaccine in this nation. What are the supply chain implications of that, and what can artificial intelligence do to help make sure that we're getting the right vaccine to the right folks in the most efficient and effective way?
I'll take this one first, only because I've been just spending an unbelievable amount of time on this one. It depends on the vaccine you take. There are 2 doses, 28 days apart, stringent, storage requirements. We've been testing out a blockchain solution embedded with AI with multiple partners, your pharmacy chains, your transportation providers, airlines, and all of that. Because, I mean, our researchers have already spotted on the security side people getting in and trying to breach that information and trying to see how they can inject in their supply or take some secrets from there. Where I see AI playing a role is with sensors and IoT type of things embedded in these containers that would move the vaccines, where, I mean, it's humanly not possible to kind of keep track of every vaccine and their storage requirements if it passed or failed. So I see where the power of blockchain, cloud, and AI are harnessed, to track these vaccines from the point it's made to, moving it to state by state. Every state is doing differently on, who's distributing them, how they want to go do that. So I see a role of AI, specifically in the storage and kind of making sure, there is a level of comfort in which we can prove through data that, a set batch hasn't been touched. So Steve, I'll turn this on to you.
No, the only thing that I would add is I feel it would be, we would miss if we didn't touch on this, is how do we use AI both from the vaccine distribution, but that ongoing continuity as it relates to health disparities. And we didn't touch enough on it, but it's been foundational to, I think, everything that we've talked about, even though we specifically did not mention it, but that's sort of the social determinants of health component. And because that information and that data has been so critical in how we've been able to build these vulnerability indices, proximity components, and will continue to be a critical piece, not only to prioritize communities for that phase 2 of the vaccine distribution, to make sure that we focus on areas that are vulnerable, not only from the health component, but then from the social and economic piece of it as well. So I think that's one piece. But the second piece is, how do we actually continue to bring those services to the areas that's most convenient for people and make that access component of it as easy as possible. That's why this dynamic connection between healthcare and the community for those social services has been more important during this pandemic than ever, because significantly larger number of individuals needed assistance, and also the supply chain of that, whether it's food, housing, utility assistance, etc., has been challenged as well because of the reliance on volunteers, etc. So I think related to vaccine is twofold. How do we use the information? How do we embed that into the vulnerability predictions using AI in the data? But the second part is, how do we place and where do we place those services in a way that's convenient for individuals to be able to access them?
Absolutely.
Dean Flynn and Dean Pullen, there are a couple questions in the Q&A. The first is, will it be practical, connectivity and cost for small groups of physicians and community-based practices to utilize AI to gather information from multiple sources on their patients, or will they need to partner with larger organizations or rely on carriers to deliver the information?
I'll take that one. I mean, my observation is we're kind of pushing down the complexity and what it would take to ingest this information to as simple as possible, right? That's been an ongoing effort. If you look at the medical the startup scene, you'll see a lot of cool technologies that are emerging. It depends on the type of use case, but my observation so far is it is getting to a point where it would make sense for smaller organization, a dentist's office or a doctor's office, to be able to take advantage with cloud and some of the computing that's available. It just makes it really, really simple to spin up the technology resources. You would need to be able to do that. So I must say I'm very encouraged by what I'm seeing there. Steve?
No, what I would say is that they absolutely can participate today as an output and infuse that information into their practices. I think for now, it needs to be relied on other partners that have that ecosystem in place, because again, to be able to create that whole person insight and then aggregate it and create it in a way that's useful, that's very specific to their application, that part does take a lot of resources that I don't see that anytime soon being able to be managed exclusively within a practice. But having said that, they can absolutely participate. A great example is something that's been around for the last few years, is the predictive models around pediatric asthma. And across the community, we've been working with over 50,000 pediatric asthma patients in a lot of practices, and those individual physician practices get a BPA alert in their EHR when a asthmatic high-risk patient is scheduled for a visit, regardless whether they come for asthma or not. So they can actually know which patient is at high risk proactively, why that's a high risk, so they can address whether it's medication reconciliation, any other components when that individual shows up. So that's already, I think, happening. It's only going to increase, but it requires this sort of an ecosystem to be in place more broadly across the medical community for it to be done at scale.
Well, I don't think we have time for any more questions. I'll allow Daniel to also thank you both. Truly can't thank you enough for this. I had asked for a 4-hour panel discussion and I was vetoed. So there you go. That's why we didn't get to everything. But both Steve and Sai, thank you so much. And I would be remiss if I also didn't thank Mari Carr and her team. And Daniel can thank his team also for all the work that goes on behind the scenes to make this work. So Daniel, closing words?
Yeah, I mean, I think we've had a great discussion, important insights, actionable insights that I think each of us can take back to our places of work to make a difference, and the way we collectively contribute to solutions, not just for today, but for the years ahead. One of the great members of our team is Valerie Johnston, who leads our healthcare MBA program, and I'd like to kick it to her to provide a wrap up.
Yeah, just a final wrap. What a great way to start the morning. thank you again, Steve and Cy, primarily for the work that you're doing and for sharing your time and your expertise with us this morning. To our two great leaders, Dean Flynn, Dean Pullen, thank you. There was a question about whether this session is recorded so that you could share it with other colleagues, and in fact, yes, it is. So you will be able to replay it both at mdschool.tcu.edu and also on Facebook as well, if you want to follow the MD School Facebook site. So please share with your colleagues, lots of good information here, hope for the future of ways we can continue to improve healthcare. Thank you so much to Jay Taylor for sponsoring the forum for us this morning. We very much appreciate your support. And thank you guys for attending. We really hope to see all of you in person next year for our annual healthcare forum. Thanks so much.
Thanks for having us.
Thank you.